coming up.
Nasal breathing is, in my view, is the key to correct sleep medicine treatment. Because, if you don't correct the nasal airway, you still have a compromised airway, even if you hold it down forward.
Amen. Amen.
Just look at the nasal improvement of this airway here versus here.
Oh, yeah.
Meters of volumetric change of his nasal passage with 6 millimeters of growth and 3 millimeters of minimum cross-sectional area improvement. Okay. So he started out at, I think it was around 3 millimeters, and he went to 6, which is normal. And he got 3 cubic centimeters of volumetric change. That's like shoving 3 dice in each nostril. So that's a huge improvement. It's basically looking, he says, you're changing things from like a little 5-year-old to a 7-foot tall person. That's how much.
Wow.
Most sleep medicine doctors, and sleep medicine is missing because everybody says, let's use an oral appliance and hold the bottom jaw forward so the tongue doesn't go back to the back of the throat.
Right.
That's all fine and dandy to keep your tongue out of there. But if you have a compromised nasal airway and you can't get enough air through your nasal passage, you have negative pressure that's going through your nasal passage, trying to suck air into your lungs. And every time your diaphragm tries to pull air through there, if your nasal passage isn't opened up, it's going to suck your tongue to the back of your throat.
We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website, www.mouthmusclememory.com. Now on to the episode.
Hi, everybody. Welcome to the Munch Bunch podcast. It's Kimmy Nishimoto and Megan Vanoy.
Hello, hello.
And today we have our friend, Dr. Bret Christensen from Idaho, my home state, Idaho. And Dr. Bret is an amazing, amazing orthodontist up there in Lewiston, Idaho. And we will let him introduce all about himself. But first, Megan is going to pull our weekly Munchie Monday affirmator.
Yes, awesome. All right. I am going to pull Dr. Bret. Tell me when to stop. All right. Tell me when.
Stop.
All right. Ooh, this is a good one. Okay. So today's episode is centered around care, which is perfect because when you guys hear Dr. Bret's background, you're going to be like, this guy cares about his patients. So care is I care about feelings, both my own and everyone else's. So I choose to use care when speaking to people, especially to those whom I share DNA with. Care means I'll try not to accidentally make anyone feel bad, which means I won't accidentally feel worse. Then no one will have to try and figure out what accidentally happened when we accidentally spoke like accidental monsters. So, and it has little monsters on it, which is really cool. Perfect. I love it. So you guys, Dr. Bret is an orthodontist of, we won't say how many decades. You can age yourself if you'd like to. 3 decades. I love it. And so he's kind of been through the whole cycle of back in the day when we pulled premolars to now the pendulum has shifted to making more space. So he's just got such a unique perspective and has, lots and lots of cases to prove it and has learned so much through the years. So Dr. Bret, tell us a little more about yourself, who you are, what you do, where you're at, how many cows you have, all that good stuff.
Let's see. I grew up here in Idaho. I did grow up on a farm. And when I was a little kid, we had 100 cows we calved out. And as I got older, I told myself that I would not be the guy that has a bunch of cows. And now I have 81 cows, and actually have a guy that's helping us calve them out. And he called me the other day, and we've had about close to 20 calves that are born, and we've had 2 cows that had twins. And one of the cows, she's just not producing enough milk, and so we ended up bringing that calf here to our place. And I have some grandkids that live in an apartment in our barn, and so they have taken over the care of this little calf, and we had to go out and doctor it today. And Wes, who's like not even 2, he's right in there, and the calf is licking him, and he's laughing. So
loving it. I love that. My grandma had a farm. She still does. And she always had goats, and there was this one goat that we swore thought it was a dog, and used to just used to be in the house all the time. And we had so much fun growing up on the farm. So I love that.
So talk to us about how your ortho education was. Like, what did they teach you? And then versus when did things start to change for you as far as the airway and things like that?
All right. Well, I was trained at a great school, University of Louisville. And golly, that was back in, let's see, well, dental school was 89 to 93. Then I was in the military for 4 years. And then I went back to school in Louisville. And so I think that was 70 or 97 to 99. Some of you guys probably weren't even born then, but you guys are pretty young. But I was trained as an extraction orthodontist. If you didn't have enough room, you pulled 4 bicuspids. If you had a class 2, you pulled upper first bicuspids, lower second bicuspids, retracted upper teeth, and protracted lower molars to correct a class 2. And then I was also trained in the surgical, doing a lot of surgeries. After orthodontic school, I was still in the military. I did 8 years in the U.S. Army, but I taught at a course at Fort Bragg. And in that 2-year stint there, I treated 400 patients. 200 of them were jaw surgery cases.
Wow.
We did a lot of jaw surgeries on patients to correct class 2s and do expansion and just the whole thing. When the military is paying for it and the soldier doesn't have to pay for it, everybody's like, yeah, I'll do surgery. When you get in private practice, nobody wants to do surgery because they don't want the $20,000-$30,000 price tag and the pain that goes with it. But when I got out of the military and came to Lewiston, I just started doing what I was trained, and that was taking out teeth. And came to Lewiston in 2001, and probably about 5 years into being an orthodontist on my own, I kept watching my patients, and initially you were taught you expand when you have a crossbite. And so that was basically the time you expanded, and the other times you just took out teeth if you didn't have room. But I noticed the patients that I expanded, that when I got them expanded, I had enough room for the teeth. But the other thing that was amazing is when I would do expansion for a crossbite, I would have parents come back the next appointment and say, wow, whatever you're doing, I really like it because my kid's not snoring anymore, and my kid's sleeping better through the night, or my kid's doing better in school. And I basically blew them off for a few years, and just was like, okay. But the more I did it, I was like, oh, I really like this expansion, mainly for the tooth aspect, because I didn't like pulling teeth. Anytime you pull teeth, you get root resorption because you're moving the other teeth a long distance through the bone. And the kids that I did expansion on, I didn't get that root resorption. And so I started shifting from extracting to expanding. And when I did that, the parents, the stories just started pouring in. More and more moms were coming saying, wow, my kid's sleeping better. And I was like, what in the world is this all about? I'm not even sure. But I really like the aspect of expanding versus extracting. And so by probably around 2010, it was probably when I just made a paradigm shift and I said, I don't need to pull teeth anymore. And when I did that, things even, the stories and everything came from parents more and more and more. And then in 2012, I have a son that was in a four-wheeler accident, and he died in that four-wheeler accident. That was in September. And 3 months later, I had a massive heart attack. And I couldn't go to work well, I shouldn't have gone to work for 6 months. I went back a month later, but I had to have other orthodontists in there helping me. But during that time off, I read a lot and I started researching on sleep medicine and kind of stepped back a few years. Soon after I opened my practice, my dad was sleeping on my couch in my house one day, and he was making a ton of noise, and I walked in and watched him sleep, and he was sitting there gurgling and sputtering, and he stopped breathing. And so I sat down and just looked at my watch and said, okay, how long is this going on? It stopped breathing sometimes for 40, 50 seconds at a time.
Wow.
And I woke him up and I took him to my office and I made my first oral appliance. And it was just it's 100% acrylic with some ramps on it and some little buttons with some rubber bands. I've got it in a presentation I could show people. And I treated him with that, and amazingly it worked. He felt better because when he wore the appliance, because his tongue was farther forward and out the back of his throat. And then I had patients that would come in, adults that would come in and say, hey, do you know how to treat this sleep apnea? I said, well, I did this thing on my dad. I can try it on you. And I did that for a number of years. And I would treat one patient and then they would go tell their friend and their friend would come to me, and I never advertised it. But after my heart attack, I was getting 2 or 3 patients a month now with this sleep stuff, and I was completely winging it. I'll be honest, I didn't have a clue what I was doing with these adults, but I was like, well, this worked on my dad, it worked on this other patient, so let me try it on you. And I was only charging like $400 a pop for
it's cheaper than a night guard.
Well, I mean, I couldn't hold myself out as knowing anything. And anyway, I finally researched a bunch of different groups out there, and I finally picked Sleep Group Solutions, and I went to one of their courses in Seattle. And I remember it was not very far after my heart attack, because my wife was still on my arm, making sure I didn't fall over and stuff. And I went to this course.
Good woman.
Yeah. And I go to this course, and in this course, they've got this machine, and it's called a rhinometer, and it's got 2 aspects. There's a rhinometer and pharyngometer. One of them measures the minimum cross-sectional area of the nasal passage, and the other one measures the oral area, so the oral pharynx and the nasal pharynx. And while I'm sitting in this course, my brain's going to all these little kids, and I raise my hand. I'm like, can this be used on kids? And they were all about showing how the pharyngometer works so that you know how to position the jaw for the best oral appliance. And I said, but can you use this nasal thing on kids? Because I have parents all the time coming back and telling me their kids are breathing better. And I would like to know what I'm doing to these kids. And they said, well, we haven't used it on kids. This is something to look at and say, oh, you need to go see your ENT and have nasal surgery so you can open up your nasal passage. And so my wife and I went home, we talked about it. At that time, it was like $35,000 for this machine and the training. And I just told her, I said, I think I need to have this machine just to see what's going on with my patients. And so we got the machine, and at that point in time, in 2013 is when we took the course. So 10 years ago. I started recording all of my patients. every patient that walked through the door, we got a baseline rhinometer reading and a baseline pharyngometer reading. And then with the kids, and even on the adults, I would measure them after I got done with expansion and then 6 months later. And I just kept gathering this data. And so we gathered this data for a long time, but I didn't know what to do with it. And here a couple of years ago, I'm talking to somebody, and I don't even remember who it was, and it was Sleep Group Solutions, because I told them, I said, God, I said, this data is so important. We got to do something about it. And so they asked me to be on a Zoom thing, and I was telling everybody about, you know, what I've been collecting. I said, but I need to have somebody who knows what to do with this data. And I guess they shared that Zoom meeting out there all over the world. And all of a sudden I had top hitters like Kevin Boyd and Ben Braglia and all these people that started reaching out to me. And I'm like, who are these people? You know? And so anyway, I end up, one of my patients works for the Lewis Clark State College, and he's a statistician and he's a PhD mathematician guy, and he's one of my patients. And I have treated all of his kids. And so I'm telling him about what we're doing. I said, I got all this data. He says, this is what I do. So he took the database and he had to clean it up because there's a lot of patients we didn't get the data in time. You know, we had, you know, well over 1,000 patients that we could look at, but we didn't have what I call clean data, you know, where these patients had these, you know, everything was done on a sequence. And anyway, so he took the data and cleaned it up, and we ended up coming up with like 347 patients that we could report on. And then he ran the data, and then I can show the data on the screen here of what the results of that were. What we do with all of our patients, and I'm an orthodontist, and I know there's lots of appliances out there, but I use a rapid palate expander, and we put it in on kids, and then we turn one turn a day for 32 days, which is 8 millimeters. So it's a standardized amount of expansion. And then we take the rhinometer readings 8 weeks after we do this, so about 4 weeks after we are done expanding, and then we take another one 6 months later when the expander is coming out. And so we've got this data. And so is it okay if I share the screen here?
Oh, please. So
let's do this. So before I do the data, I'm going to show you, this is one of my little patients right here. Okay. And her mother did these videos without me knowing, and then she said, I got videos to share with you.
Smart mama.
This little gal, just listen. Okay, that's her oral posture before we did anything. Okay. Mouth wide open, snoring, struggling to sleep. And this right here is 1 week into treatment. Mouth still open.
Less open, but still open.
Mouth is open, but less noise. Okay. This is 2 weeks into treatment. Mouth closed. You can hear the air going through her nose, though. Now the mouth is closed. And this is at 4 weeks.
Wow.
Sweet baby.
Mouth completely closed. Barely hear the nasal airway. And so, and I've got other patients, moms have done this for me too, that I can show, but this is what drives me with everything that I do, is being able to see these little kids go from a total open mouth breather at nighttime to a closed mouth nasal breather. And so
and that's fast too, like that's just 1 month.
Yeah, in 1 month you completely change them. This is the story this is what changed me. So this right here is my granddaughter Everly, and I was off at a tongue tie course in Canada. And my daughter calls us on the phone and says, Everly stopped breathing last night.
Oh.
And, I was, my daughter says, what can we do? And I says, we could, I hadn't treated 3-year-olds yet. And this is her ceph.
Holy
baby.
moly.
Here's her tonsils completely touching the back of her throat. And so when I came back from Canada, we took these images and we said, okay, what do we do? And then this right here is her symptoms that she was having before we did expansion on her. And so she had night terrors. We didn't realize that she couldn't smell until after we did the expansion. And she grew up with a dog in the home. And within about 2 weeks of expanding her, she started complaining about how the dog smelled. She'd grown up with this dog. The dog was there before she was
like,
born.
Who's this sneaky dog?
And so, but she would wake up 6 or 7 times at night, and she would not wake up happy. She would fall asleep. I remember going to lunch one time with them, and she fell asleep in her food. She was exhausted all day long. And she was also a bedwetter. Even though during the day she was potty trained, at nighttime she would wet the bed. And then post-expansion, she didn't have night terrors, smelled things, sleep through the night. She woke up awake and ready to go. And this happened within 1 month of treating her. So this is little Everly. And if you look at the gap in her front teeth, that gap is gold, because when you do an expander, let me jump over to this one real here. This right here is what we now call the Everly expander. It's in our code of the Everly expander that we treat little 3 to 5-year-olds with. But that gap is gold, because when you do an expansion on a little kid, I've even done expansion and got this gap on 28-year-old women.
Wow.
But when you do and you get that expansion, what happens is the maxilla, the suture splits and everything spreads apart. And as the maxilla expands, the nasal passage expands also, and it opens up that nasal airway so they can breathe. And as soon as they can get their air through their nasal passage, then they can close their mouth. The reason her tonsils were huge is because her tonsils are always just dried out from her mouth breathing all the time. And when you look at the ultimate cause of this, now these are not my fingers, these are mom's fingers. Here we have a little posterior tongue tie. So that's the underlying cause of these underdeveloped jaws. That's a whole new lecture in and of itself. And so what I do is I do rapid palatal expansion. I do slow mandibular uprighting. It is mandibular expansion. And so this is what we call a fixed lingual expansion appliance, and then a rapid palatal expander. I used to, what I was trained to do was I was trained to turn it morning and night for 2 weeks. And then over the years, I said, you know what, I think I can get the same thing by turning it once a day versus once or twice a day. And I think you get the same results with less pain and discomfort with the child. Because I still get the gap on all of these patients, and I still get that maxillary growth. And then the mandibular expander, we turn that one once every 3 days for about 3 months. And what that does is it takes the buccal segments of the lower arch and uprights them and expands the molars and bicuspids and the primary teeth to match up with that new upper jaw that is now wide. Patients that are usually over 12 and have all their permanent teeth, I do this instead, just because it's mainly you're uprighting the buccal segments. We do the expansion. Here we got the expansion, then we have braces on the bottom. We put these little buttons on the lingual of the lower first molars and first bicuspids. Then they wear these crossbite elastics, and that just takes the buccal segments and takes them and stands them up in the bone so that they're going to match up with the upper jaw.
Wow.
And so when we look at what happens when you do expansion, what I do is I use this Rhinometer. It's from EcoVision. And this right here will show you, this is our patient compilation that we have is about 5 years of patients, 347 patients. And we got the minimum cross-sectional area, which is the narrowest part that the patient has to breathe through in their nasal passage. And then also the volumetric change of what happens to how much air can go through your nasal passage. In our study, we had youngest is 2 years old, up to 30 years old. But the average age of the patient, when you compile everybody, is around 11 years old. We use the Hyrex expander. And like I said, we turn the key 32 days, which is each turn is 1/4 of a millimeter. So it's a standardized 8 millimeters of expansion. When we look at this chart right here, this is a percentage of growth of the craniofacial complex for the age. And so when you look at babies, it's interesting is that they grow, males and females grow about 54% of their head growth in the first 2 years of life.
Oof. Okay. He's got a tiny head too.
And so when you look at that, it's like, okay, if you can correct a tongue tie at birth, and then that tongue sits and pushes into the palate from birth, that's where you're going to get your best results. But I'm getting all these kids later, and so it's like, well, okay, we didn't fix the tongue when they were getting the majority of their growth. What do we do about it now? But if you look in here even farther, by the time they're 7 or 8 years old, which is when the American Association of Orthodontists say this is when you start treating kids, they're at 80 to 85% of their growth is done. Okay.
Crazy.
And the other part is if you have a kid that you wait until 8 years old, you could have treated them at 3 years old. That's 5 years of oxygen desaturations that you're missing out on a kid. So what we did is we took this data right here and we said, okay, well, we know how big the minimum cross-sectional area should be by the time you are an adult, and that is about 6 millimeters. Okay, so if we go back and we say, okay, by the time you're 2 years old, you should have 54% of that, and which is 3.2 millimeters. 3 millimeters is basically a coffee straw. So a baby that is born to 2 years old can actually live by breathing through 2 coffee straws. They don't have a big body. By the time they're 4 years old, they should have 4.5 millimeters of the minimum cross-sectional area. Then it really just slows down and goes very slow, throughout the years. What's interesting to me is I have adults that come in that have 2-year-old airways. And they have very narrow upper jaws, and they can't breathe, and they have sleep apnea, or they have upper airway resistance syndrome. And then you look under their tongue, and they're tongue-tied, and you're going, you never grew from the time you're 2. And most of those patients, not most, a lot of them have had 4 bicuspid extraction because they didn't have upper jaws that were developed enough for having all those teeth. And so they did traditional orthodontics of taking out teeth. Then if we look at the volumetric size of the airways, and we know that as an adult, you should have about 7 cubic centimeters. So then we extrapolate that back and we say, okay, as a 2-year-old should have 3.8. And that's from the tip of the nose back to basically the adenoids. Okay, so that's how much space, is through those convoluted turbinates and everything that we look at and say, okay, and then as you grow older, that space should get bigger. And so when we look at our study that we did, this right here is the data from that study. And out of the total number, which is the third group down here, that's all of the patients. On average, with one expander, and this is left and right because we collected data on that, we got about 1.2 millimeters of minimum cross-sectional area improvement. And so that's about a 42 to 46% improvement. But I asked my statistician guy, I said, there's a lot of patients that have a lot better results than that, but this is, the average over 350 patients. And I said, take the top 200 patients. So he worked the data. He says, well, out of the top 200 patients, they get about 1.7 millimeters of improvement, which is a 65 to 70% improvement of their minimum cross-sectional area. I said, okay, now take the top 100 patients of that 347 patients. That's a 2.3 millimeter to 2.4, which is 96 to 100% improvement of their cross-sectional area.
Wow.
So with this, which is interesting, is when you look at a little kid that comes in and they have a 1.5 millimeter airway, which is half of a coffee straw, I can look at the parent and say, this kid's going to need more than one expander. When I was treating patients before I looked at airways, I would do a one expander and say, one and done. All right, we got enough room for the teeth. Now I look at all these patients and say, okay, let's do the expansion. Let's remeasure the airways. And a lot of these kids that start out at 2 millimeter airways, they're now up to 4 millimeter airways. But if you go back to the this right here, a 4 millimeter airway is still only a 4-year-old. Okay. And so we're looking at doing a second expander on them to make sure that we get them up to an adult size airway. I don't know what the standard deviations and this effect size means, but my statistician says this is basically, he says this is a huge effect size. He says usually you're seeing something that's like 0.1, 0.2, something like that. And he says, you're getting 0.9. He says, that's a huge improvement. It's basically looking, he says, you're changing things from like a little 5-year-old to a 7-foot tall person. That's how much.
Wow.
So the other part of this is the volumetric change. And this right here, when you look at a cubic centimeter is the size of a dice. And so with all 347 patients, we got about 1.5 cubic centimeter improvement on those patients. So that's like taking 1.5 dice and squishing it and making it go through the nasal airways. That's how much of an improvement you get.
Awesome.
But in the top 100, it's over 3 cubic centimeters. That's 3 dice in each nasal passage. That's 6 cubic centimeters change in how much better they can breathe with one expander.
Wow.
So that right there is super significant when you're looking at being able to improve somebody's ability to breathe through their nose.
So Dr. Christensen, when we're talking about the airway here, are we talking about the nasal airway or like the classic airway, which is like we refer to as like behind the tongue?
We're just looking at nasal airway on these right here.
Okay. Wow. Thank you for the clarification.
Yeah, this is all nasal airway improvement.
Wow.
From the tip of your nose back to your adenoids is where you're looking at that space right there. And this is where I think that most sleep medicine doctors and sleep medicine is missing because everybody says, let's use an oral appliance and hold the bottom jaw forward so the tongue doesn't go back to the back of the throat.
Right.
That's all fine and dandy to keep your tongue out of there. But if you have a compromised nasal airway and you can't get enough air through your nasal passage, you have negative pressure that's going through your nasal passage, trying to suck air into your lungs. And every time your diaphragm tries to pull air through there, if your nasal passage isn't opened up, it's going to suck your tongue to the back of your throat. Okay. If you have a good open nasal airway and the air flows smooth, and that's what I just had a patient that was in today. He's in his late 40s, and he's in a Schwartz appliance, has been since September. So that's almost 4 months. And he goes, this thing is amazing. He says, I have forgot to put my Schwartz appliance in. It's a MAD, so it holds his jaw forward too. He says, I'm sleeping so much better with the appliance, but sometimes when I forget, I still sleep, but I'm still getting better sleep because I'm breathing with my mouth closed, not my mouth open, and I'm not snoring. He says, I'm sleeping really good with the appliance in, and I'll continue to do so. But we measured him, and he should be measuring around 42 millimeters, and today it was at 36. We started out at about 32.
Wow.
Okay. And so he's got a long ways to go, but just think what happens when we get his upper jaw grown. He's gonna be in that much better shape.
That's a really good point too, because I feel like in dentistry, sometimes people get all excited about doing the sleep appliances and the snore guards, but they disregard the nose piece of it, which is the most important piece, which is why they should also work with the myofunctional therapist, because we can teach them how to breathe. And then some people have such small anatomical nasal structures. Like I know that I had a deviated septum, large turbinates, and I would always use a mute nasal dilator, and that helped me to breathe and to be able to sleep through the night. But since I had my deviated septum surgery, it's like night and day. There's no comparison to the mute at all. Like the mute definitely was not enough. So I can understand the power of this research and the stats, because it doesn't, when you look at the numbers, it's like, okay, cool. But when you actually think about it, it's a huge improvement.
Oh yeah. Well, and I actually, when you were talking about like how your granddaughter like didn't realize that she couldn't smell, that was one of the first things that Kimmy had messaged me about her boyfriend, fiance for another few weeks, was that like Andy all of a sudden smelled things that he like didn't know he couldn't smell. And that was like one of the most amazing things. And I think you kind of forget that there's more than just breathing, right? Being able to smell, being able to like use your senses. It just opens us up to so much more when we're able to do that. So I think that's just so cool.
We want to introduce the Spot for Tots course, a parent's guide for toddlers ages 2 to 5 for mini Mayo. We have Megan and Kimmy going over nasal hygiene, myofunctional exercises, breathing exercises, tongue tie healing protocols, and then we have Jenny June going over sleep hygiene, and Kelsey Baker going over feeding therapy and body work. The course is $297, and the link will be in the description.
Have you guys read the book Breathe by James Nestor?
Yeah, well, he came on the pod earlier this year too. So
he did.
Yeah. Mm-hmm.
Well, that's pretty cool. He was our keynote speaker in Georgia.
Mm-hmm. Yeah.
And that book is amazing when you look at the study that he did, him and his friend. Within 3 days, both of them had sleep apnea where they didn't have it before, just by plugging your nose.
Yeah.
Nasal breathing is, in my view, is the key to correct sleep medicine treatment. Because, if you don't correct the nasal airway, you still have a compromised airway, even if you hold it down forward.
Amen.
So
yeah. Oh, I love it. I keep talking about moving to where all you doctors are who are doing these amazing things with your patients. Because Isabel is going to be 2 February 7th. So you guys feel free to send your gifts for my 2-year-old. But she was lip, tongue, cheek tied. She has a high neuro pacifier palate. We're getting rid of that. Pacifier fairy is coming. But you can see that we're working with her on the munchie, and she sleeps, luckily she sleeps with her mouth closed, and obviously I just stare at her all night long, so I probably should work on my own sleep, but them's the perks of being a mom. And I know that like as soon as she turns 3, we need to do something, and we're doing some kind of mini Mayo-y type stuff with her right now, but I know we're going to need more, so I'm like, oh, looks like a road trip to Lewiston from Portland might be might be in the books.
I actually have patients from Portland that come here.
Perfect. We'll carpool.
I have patients. I have patients from Texas, Montana, lots of them coming down from Spokane and Post Falls. I have patients
Yeah.
come from Boise up here. And ultimately, I would like to just train a lot of people so that those patients can stay where they're at and be treated there. So
yes, that would be the dream. And I've got somebody in mind for you down here, but we can talk about that, off screen. But yeah, I mean, it's so cool seeing what you guys are doing and seeing how early we're able to help people. And, I know the impact. Obviously, I see it with my patients all the time. I see their lives and their health change right before my eyes, but it's just so cool to see that there's data because, how many times do we get told that, there's just not enough research on this stuff. And you're like, how hard are you looking?
I'm gonna bring up my adult thing because I want to show you guys, I want to show you guys a case. We were talking earlier about my dad and everything like that. And so this is my parents right here. My dad's mother died, I think, in her late 60s of dementia.
Oh, wow.
When she died, they did an autopsy, and her heart was twice the size of a normal human heart.
Oh my God.
And I remember as a little kid, she died when I was about 7 years old. And I remember a few things about my grandmother. One of them is that she made the most awesome mint tea. She would go down the ditch banks and gather tea and dry it, and then she would boil it and put honey in it. And the other thing is she lived in a log cabin, an old log cabin that was only heated by wood.
Wow.
With my grandpa. And we slept on this trundle bed that had this big dip in it. And all the kids slept on this thing and we all just fell to the inside. But I never slept when I was at her house because she slept in the other room and she always made so much noise that I never did sleep. And my dad, when we figured out that he had sleep apnea, he finally came to me later. He says, my mother died of sleep apnea. I know it because she snored like a freight train. This is the appliance that I made for my dad. What do you think of that?
I love that it says crazy thing worked.
and yeah, just, it wasn't anything fancy. It's not a Schwartz. It's not a tap. It's not a prosomnus. It's a bunch of acrylic. All it did was pull the jaw forward. Let me see if I want to get to a case that I want to show you guys.
I'm surprised you didn't complain about it. I feel like family always complains about everything you make them, right?
Oh my gosh. Yes. Family are the worst patients. But actually, it's funny, Dr. Christensen, because you talking about kind of how your dad was your guinea pig. My dad was my guinea pig because he snored like a freight train and he would like shake the house. And, I was trying to convince my parents that I wanted to switch careers. And so, we did myofunctional therapy on my dad and had a lot of success. So, they've not that they haven't always been supportive, but they're like, all right, there might be something to this.
Yeah. My dad's 84 now, so he's outlived his mother.
Wow.
So, which is pretty cool.
Yeah.
All right. So let me show you. I've got to show you a little bit of precursor before you see this case, but this case is my flagship case. But anyway, so this is the appliance that I make now. It's called a Schwartz with a MAD, and it's got little fins on the side here, and then it's got these little expander screws that come up here, and that's how we design that so that we can change the forward, and then we change acrylic with the vertical on that. We use a pharyngometer to dial all of this stuff in to set the patient up for the right vertical and horizontal position with the pharyngometer to get them for their sleep apnea. And then with the expansion that we've got in here, these expansion screws, then we slowly over time go in and grow the upper jaw and help with the nasal airway. There are some patients that don't have sleep apnea and don't need a MAD. And so we don't put all the other stuff on it. We just use the regular Schwartz appliance. And this is what I did on myself back in 2019. And I grew my maxilla at 8 millimeters.
Wow.
And I'm a triathlete. And I went from mouth breathing during all my training to now I bike 50 miles with my mouth closed. I can run on flat ground with my mouth closed because I went and grew my maxilla and changed my nasal airway.
And how old were you when you did this?
I'm 55 now, and almost 56, and
Amazing.
2019 was what? 4
3
years ago?
years. Yeah,
3
3,
years
4.
ago? Yeah.
That's
So I
amazing.
at
So it's
50
never
years
too
old,
late.
You're never
yeah.
too old.
But know that it took a year and a half
Right.
to accomplish this. It's not, you know, everybody wants something that you can put in there and you're done in a week or
Right.
a month. You know, they want something that's fast. I saw probably 10 or 15 Schwartz appliance patients today, and I had to turn their appliances back because they were trying to go too fast. Their appliances weren't working, and they were getting tipping of their teeth versus growth of their jaws. And I have to, you know, a lot of patients there, everybody wants to get in there and just get things accomplished so quick. And it's like, this is a year and a half, 2 years, sometimes a 3 year process to accomplish that. And so you can't be in a hurry to do this. A lot of these patients, when they walk in through the door at about 3 to 6 months, are like, oh my gosh, I can't believe how much better I'm breathing through my nose. So this right here, I'm going to show you is an upper airway resistance patient. Okay. And let me make this bigger. I didn't bring his pictures on here, but when we started him, he was 31.8 millimeters. Okay. That's the width between his 6-year molars. And crooked and crowded teeth. This is him with the Schwartz appliance. I'm just going to go back and forth. We did have to put some upper brackets on because his upper teeth were tilted back. Look at the amount of expansion we got with him with the Schwartz appliance. Okay.
Amazing.
All right. So here's his arches. And we only put braces, you know, up here on the top guys to get because his upper teeth were tilted back. Here's his lower arch, and we've expanded and given him a lot more tongue space. I mean,
and that tongue tie though.
Oh yeah, we're gonna get to that. You can see that right there, but just look at how his tongue is sitting on top of these teeth back here. Now his tongue totally got a lot of space in here. Okay. And those are the fun ones to release.
Oh yeah.
So, and like I said, you just can't make this stuff up. These people all have posterior tongue ties. All right. So here's his rhinometer readings. This guy's in his 40s. Okay. When you look at the lines over here, and it's kind of blurred on here, but I just took pictures before I went to Georgia. But here's his before rhinometer. Here's his after. See how much higher all of the readings are.
Yeah.
Okay. And here's the thing. We only got 6 millimeters of expansion with the Schwartz. So if you go back to here and you measure, he's at 38 millimeters. He was 31.8. We only got 6 millimeters of growth. Okay. But when you look at this, we got 3 cubic centimeters of volumetric change of his nasal passage with 6 millimeters of growth and 3 millimeters of minimum cross-sectional area improvement. Okay. So he started out at, I think it was around 3 millimeters, and he went to 6, which is normal. And he got 3 cubic centimeters of volumetric change. That's like shoving 6 dice in, well, 3 dice in each nostril. And this is
what a visual. What a visual.
But if you don't have something to measure this, you're just guessing. You're saying, oh, so great, it works. I had before I went to Georgia, I just said on the whim, I says, measure the next 2 Schwartz patients, and both of them had the same kind of results.
That's awesome.
Okay. So this right here is my flagship case. This should change everybody's mind on what you can accomplish with Schwartz appliance and slow mandibular growth. This is a 3-year case.
Wow.
Okay. So this is Kelsey. Look at how narrow her upper jaw is. Okay. And here's she was when we started, 24 years old. Highest weight was 350 pounds. Age, I have 60.
Yikes.
Oxygen desaturations down to 70. Average heart rate, 84, high 114. 114, that's what I bike at.
Wow.
I bike around 120. Wow. Okay. She was diabetic. And wait until you see her tongue. And So here's her
Wow.
okay. So her whole upper jaw fit inside of her lower jaw. She had severe sleep apnea. And
woof.
Oh, mama.
okay. I need to get an updated one. We need to do a second revision on her, but I didn't get an updated one before I came to the course. Here's her Epworth sleepiness scale, 23.
She's a sleepy girl.
Yes.
Yes.
Okay. This is kind of fun.
Wow.
This is a Facebook post that she put on about a year and a half into treatment with her. And she says, I have a lot of weight left to lose, but it is good to know I'm smaller than my wedding day. And also, look at that smile. Braces are paying off. She never had braces yet. All we did was Schwartz.
Wow.
Wow.
How small her upper jaw was
Mm-hmm.
and where she was at. You know, she's lost a ton of weight. Here's her oral airway.
Mm-hmm.
That's a huge improvement.
Question about the weight piece. Are we thinking that's due to some of the sleep improvements?
So she had tried to lose weight for years. She was a heavy child. She could not lose weight until we got her sleep apnea under control.
Okay.
Must be that hormonal
the
sleep
leptin
cycles.
Yeah. Just look at the nasal improvement of this airway here versus here.
Oh yeah.
This is so cool to see your perspective from like the nose piece, because we're always like honed in on behind the tongue.
Yeah.
But the nose piece is fascinating.
That's the key to sleep medicine. Here's her airway. Here's her oral airway. She goes from tiny to a lot bigger.
Well, bam.
Okay. Now here's the fun part. Okay, this is Kelsey's before pictures. This is Kelsey today.
Wow.
Okay.
Wow.
Okay. So Kelsey lost a lot of weight. I think it was close to 150 pounds.
Wow. Good for her.
Oh my word. Look at those straight teeth.
No surgery. Just very, very slow expansion for over 2 years before we even went to braces.
Wow.
Wow. Oh, what a beauty.
Okay. Didn't really expand her mandible very much at all. We just aligned some teeth down there. Went from a 28. And so, you know, when you look at this, you go, okay, she went from a 28.6 millimeter width to a 34 millimeter width.
That's me.
But then when we measured her during Schwartz expansion, she was at 39 millimeters. When we stopped this Schwartz expander, she came back because some of that was flaring. Okay. And then in the end, we end up getting, what's that, about 6 millimeters of growth.
Which is still huge.
So we still got 6 millimeters of growth, even though, you know, at the time we thought we had gotten 10. But we had probably 2 millimeters of flaring.
Right.
And anybody that says, you know, all you're doing is flaring the teeth, well, you do flare the teeth. That's part of the process. But then when you take them off, those teeth come back and you don't have the teeth that are flared. Nasal airways opened up a ton. And her oral airway, this is the pharyngometer. Oral airway was clear down here to up here.
Nice.
Okay. And this is the most exciting part. Her AHI went from 60 to 6.
Wow.
Okay. Oxygen desaturations went from average of 70% to she dropped down to 89% 3 times in 5 hours.
Wow.
So only 3 episodes did she ever go below 90 in a total of 5 hours. She went from 350 pounds to 225. She's still working on it. She was an obligate mouth breather to full-time nasal breather. She's no longer diabetic.
Wow. Chills.
Amazing.
So I want you to see this. She sent this to me.
Hello, my name is Kelsey, and this therapy has changed my life. I used to be 125 pounds heavier, on the verge of a heart attack. My body was shutting down. I was only 23 years old. Not only do I have a beautiful smile, but my jaw no longer clicks. I can breathe through my nose, which I never could before. I've lost 125 pounds and I'm off 4 different medications. I can work out and exercise and sleep better than I ever could in my life. I have gone from having 64 breathing episodes per hour with sleep apnea to only having 6. I am astounded at the changes that have been made because of Dr. Christensen's help. Thank you.
Oh, that's wonderful. Thank you so much for sharing with us.
This is why I do what I do. I love what I do. And I think one of the big things for kind of a take-home message for anybody that is getting into sleep medicine, this is not a I guess a get-rich-quick scheme.
Right.
This isn't a get treatment done quick type of thing. Yeah, little kids, it does happen pretty quick with them, but with adults, it's a very slow process. And as you saw in multiple patients there, what's the underlying cause? The tongue that doesn't function right. And so my whole practice is full-on sleep medicine from babies till I'm treating people in their 80s. And I'm growing people in their 80 years old, which is cool.
Yeah, you're so cool.
That's so cool. I love that.
Well, Dr. Bret, I have one more thing I wanted to ask you. Sometimes in like the airway circles or like the forums that you read, there's some controversy over if rapid palatal expanders cause scar tissue of the maxilla. Can you debunk that for us?
I'm just trying to figure out who's the first person that said that, because just because somebody says that doesn't mean it's the case.
True. And so many things in life.
There's so many times when somebody says something, and that's why I was never a data person. I was always a feel good. Does it feel good? Yeah, okay, I'll go with whatever it feels. When I started doing this sleep medicine stuff, I said, I have to have something to back this up.
Yeah.
And just because somebody says you have a scar tissue up there, show me the data, show me the histological, things. I mean, because I see my CT scans after expansion and after I've held, after I've held that little kid in there for 6 months and after treatment, there's bone across the top of the palate. It's not cartilage, it's bone. I look at my adult patients where we're changing their whole maxilla. It's remodeling of the maxilla. We're changing the bone. We're not, and I guess here's the other question. If somebody could come up with if they could show me where it's scar tissue, so what?
Yeah. Good point.
If it's scar tissue and it helped them, be able to breathe through their nose and they've got a better nasal airway, show me it and then maybe I'll believe it. But I have yet to see anybody that has shown me data or any type of concrete evidence that says they're scar tissue, although I see on my CT scans that it's bone. But even if it was, look at the data of what rapid palatal expansion does. Down the road, we're getting 1.5 to 3 cubic centimeters of improvement of nasal airway function in the volumetric side and 1.2 to 2.4 minimum cross-sectional area. That's huge. Whether it's bony or if there is a scar, like I said, show me the data. I would love to see it. But there's, traditional expansion has been around for years, and we correct these cross bites and they stay. And the only reason that cross bites don't stay, and I have patients from the past that I did expansion on them, and I took the expander out, and I'd see them a few years later, and they were back in crossbite. Guess what I never looked at before?
Their tongue?
Yeah. I never looked at a tongue before I went into sleep medicine. And if you have a tongue that's tied to the bottom of the jaw and you don't have it sitting up there, I mean, I tell patients every single day, the best retainer ever made is a good functioning tongue. It's not that piece of plastic holly that we put in their palate. If you have a functioning tongue that sits there and keeps the pressure into the palate, you're not going to get the relapse. So
good. I tell my patients that too. So
Ooh, I just thought of one more, and then I promise I will let you go. I won't dig in anymore. But sometimes I feel like in our space, like Megan and I are very much like meeting people where they're at. People have to pick providers that they can go to because, sometimes like geologically or geographically,
there you go.
I can't come to Lewiston, Idaho to see you for braces as much as I would love to. So I would have to find someone in my area. Can you talk to us about, like, as long as they're not doing bicuspid extraction or extraction ortho, if you do traditional ortho for your kids, are you ruining them? Because that's another kind of unpopular opinion that is kind of circulating within the forums and the groups now.
Traditional orthodontics, with extractions, this is something that somebody brought up to me a while back, and I have an orthodontist in our town that I lectured at one lecture, and then the American Association of Orthodontists found out I was lecturing, and so they sent people to lecture after me. And I lectured all about nasal airway and improvement of the airway and everything like that. And I never talked about sleep apnea. I just talked about improving airways. And he got up and he says, well, extractions don't cause sleep apnea, and headgear doesn't cause sleep apnea, and extractions don't cause nasal airway or all these different things, and neither does headgear. And I thought about that a long time, because the forums of everybody's, oh my gosh, if you take out 4 bicuspids, you're going to cause sleep apnea. They had sleep apnea to begin with. They had small nasal airways. By taking out teeth, you just didn't make it any better. You left it where it was. Okay. We want to blame the orthodontist for everything. And I have my own patients from back when I was extracting teeth coming in for sleep consults, and I'm treating them. And I look at them and I say, you know what? I gave you a nice service in that your teeth were straight by the time we were done. I says, could you breathe through your nose before we, back then? And they're like, no, I've never been able to breathe through my nose. And so the cause and effect, I don't think that extractions cause sleep apnea. I don't think headgear causes sleep apnea. I think that those constricted airways were always there. And so, trying to blame a profession that they're causing things. No, they're just not diagnosing sleep medicine, and they're not treating sleep medicine. They're treating teeth. In the end, I would hope that in the next 10 years before I retire, that I can get the word out, and that we can change the thinking of orthodontics to incorporate sleep medicine and looking at those airways before we start treatment, and treat the airways first, and the teeth will come along with it. And so I don't know if I answered your question, Kimmy, on that.
No, that was great. That was great.
And so, does traditional orthodontics cause these problems? And I would say, if you take out 4 teeth, as somebody that was super crowded, you didn't make it, you made their smile prettier. And if they were that crowded, you probably didn't change anything except for the straight teeth.
Right.
Okay. If you went in and expanded that person, gained room for the space, and improved their nasal airway, improved their tongue space, you improved that patient's airway. And so that's what I'm looking at, and what I would like the orthodontics to look at and say, okay, yeah, if you had pulled teeth, you probably made them smile prettier. But if you didn't pull teeth and did expansion, you're going to get a much better end result. Mm-hmm. You just can't be in a hurry. Orthodontists are, I mean, I'm seeing 80, 90 patients a day.
Wow. And you have 80 cows.
Yeah, but I have a friend that takes care of those.
Delegating.
Yes. And I have an incredible team of women, and one guy, we've got a man lab tech that came in with us this last year because we were so busy. And no, you can't do this stuff on your own. It's not me. I'm nothing without my team. I'm in all aspects of life. So
I love that. So Dr. Christensen, are you on social media, or what's your website? Where can people find you?
christensenbraces.com, and I Christensen Orthodontics on Facebook. I think I'm on Instagram. My wife takes care of all the social media stuff.
Perfect.
I'm just busy taking care of patients.
Perfect. Again, delegating.
Yeah, we updated our website back in 2020, I think.
Awesome.
And we need to update it again because there's a lot of data that we've got that we can improve. But a lot of patients that come to me from Texas, they looked at our website and went to just learn about things, and all of a sudden they're like, okay, that's why, it's really humbling when you have a whole family that comes from Texas to see you every 3 months.
Wow.
And I tried to get him with the other orthodontists, but the other orthodontists just they wouldn't look at him the same way.
Mm-hmm.
So yeah.
No one else is like you, though. You're very special.
I'm not special. But I sure would like to help change things in the future.
Yes, I love what you're doing, and I love that you're trying to change not just the dentist mind, but the orthodontist minds, because sometimes I feel like we're very intimidated by orthodontists.
Orthodontists are a very proud group. We go to a lot of school, and we get done, we're told that we're the top tooth movers in the world. And that's one of the things that's hard to break into, because one of the things that I think is the big detriment to the world of orthodontics is orthodontics being so proud that they don't include their general dentist in everything. And I was one of those guys for years. When the general dentist would do braces on somebody, that would just really tick me off. And I was like, you don't know what you're doing. You didn't go to school. And my little brother started doing orthodontics, and he doesn't live in the same town, but he started doing orthodontics, and he and I had a falling out because I told him, you're not a specialist. You don't even have a Ceph machine. You shouldn't be doing this. And I told him one time, I says, if you have a case that goes to court, I says, I will fry you within 2 minutes. I said, you will lose the case, because, and I was a very proud person. And I thought that I knew it all. And then I went into sleep medicine and found out I was clueless. I knew how to move teeth. And now I'm training my little brother to do expansion and help his patients. And he's a patient. He's a sleep apnea patient that's doing expansion and changing his nasal airway.
I love
it. I think that, with the Invisalign, you don't even need an orthodontist. You can straighten teeth now. So what is the use of an orthodontist? You don't need an orthodontist to straighten teeth. You can order a set of trays through the mail. You need an orthodontist to diagnose sleep medicine, diagnose the underlying causes and treat the underlying causes. And the world of orthodontics is going to go away if we as orthodontists don't step up and become doctors and treat the patient versus being tooth technicians and treat the teeth. So
I think that's such
powerful.
a good point.
Powerful.
You're so cool, Dr. Bret. We just love you. We think you're the just positive coolest.
Yes, I agree. Okay. So you guys, if you want to find us on social media as well, we'll link Dr. Bret. We'll chat with his wife and find out his handles. But you can find Kimmy at Mouth Muscle Memory. You can find me at NWMFT. And you can find us both at the Munch Bunch Mayo podcast on Instagram and definitely on YouTube. And we will be looking forward to the next Munchy Monday.
Bye.
All right. Thank you. Have a good day.